Good evening. Yeah. Good morning, good evening. So we start in a minute. Yeah. So I said today's topic is secondary hypertension. Now, this topic would be like a combination of everything. So this is where we'll see that how the RAS system, once it is disturbed, what will really happen. When we talk about primary hypertension, which we discussed last time, so just consider that that is a foundation. And secondary hypertension, this is something which you'll be encountering into your clinical practice. Then you'll find that there is one disease, but it has got several symptoms. Say, for example, someone can have headache, someone can have, say, blurring of the vision. Right? So all those things, how they are combined together, and that's what we'll try to come to a conclusion. How to really diagnose. Okay, so it's time. Let's start. So here it is. When we said that when the blood pressure is high, and blood pressure is nothing but this is the vessel, this is the artery, and the pressure which is imposed by the fluid which is inside. In our case, we'll be dealing with the blood. So it is the pressure which has been generated onto the walls. That is what is called as the blood pressure. And when that blood pressure rises, so then that is called as the hypertension or the high blood pressure. Right? As it is said that 90%, it is primary hypertension. That is 90%. But this 10%, which is also called as the secondary hypertension, where hypertension is because of some other cause. Now, this thing is more tricky. Correct? This thing is more tricky because you have to really identify the reason and why it is, because it would be associated with so many other things. So what we learned till this point of time was that blood pressure is what? Right? Blood pressure is nothing but the cardiac output. Right? It is the cardiac output multiplied by total peripheral resistance. Correct? So when the blood pressure has to increase, so either the cardiac output is increased or there is increase in the total peripheral resistance. Now, total peripheral resistance, I hope you remember, this is the artery and which is divided into several arterioles. Then the venules are formed and then the vein is there. So this is the artery, this is the vein, and this is where there are arterioles and venules. We are more interested in arterioles because when they are constricted, so there would be increased resistance, right? Because now the caliber has been decreased, so there is increased resistance, and that will lead to increased pressure, the increased back pressure into the arteries. Where can it really occur? Well, for this, just one simple word that would be sufficient, and that is a vasoconstrictor. So whenever we'll be coming across the word vasoconstrictor, that means the vessels, they will be constricted. When they are constricted, so there is a less space, so there is more pressure on the walls. So this is one what we'll remember. And second, whenever there is stimulation, right, stimulation of sympathetic nervous system. Now it could be physiological, it could be pathological. Okay. No, you have not lost anything. We just started, and our today's topic is secondary hypertension. And in secondary hypertension, That means when the hypertension is associated with some other diseases. So which are the diseases with which blood pressure is high, hypertension is associated? So in that, we learned about this first formula, that is the blood pressure, which is equal to cardiac output in total peripheral resistance. Total peripheral resistance is that this is the artery, these are the arterioles, right? Arterioles, venules, and then it is the formation of vein. So if there is constriction over here, there will be a back pressure. So the key word is vasoconstrictor. When the vessels are constricted, it will lead to increased back pressure. And second, when there is stimulation of sympathetic nervous system, right? Sympathetic nervous system. So sympathetic nervous system, its function is, it will tell heart to beat fast, it will tell heart to beat with force, right? So there is increased cardiac output, So we know that there would be increased blood pressure. But at the same time, sympathetic nervous system will also lead to vasoconstriction in specific areas, especially digestive system, right? So you don't feel like when there is fight, you don't say that let me eat something first and then we fight. No, right? During exam, right, you don't feel like eating. The reason sympathetic is triggered. So when sympathetic is triggered, it will shut down those systems, because its importance is right now it is fight and fright. So that is to be taken care of. Right? So these are the two things. Now in many of the cases, we'll see that some of the tumors, they release, because sympathetic nervous system is what? Sympathetic nervous system is adrenaline, correct? Adrenaline, noradrenaline. So they are secreted. These are the neurotransmitters which are secreted, and that is nothing but stimulation of sympathetic nervous system. So for any other reason, if adrenaline, noradrenaline is secreting more, or they are secreting normally, but their response, the tissues, they are going for hyper response, right? So we'll study all these things, that what can really occur. But the foundation will remain same, and that would be, there has to be increase in the cardiac output, or there has to be increase in the total peripheral resistance, or both. Right? So we start with the first and the most common. This thing is most common. Whenever someone is having high blood pressure, this is the commonest associated thing, and that is what is called as the chronic kidney disease. Chronic kidney disease. CKD. On case paper, when you find CKD, this is the chronic kidney disease. Common so much that more than 80% of the patients, they will be having high blood pressure, hypertension. Should not be a very complicated thing. Why it should really occur? Blood pressure. Because kidney is not functioning. What was the function of kidney? Kidney's function was to throw the sodium out. Right? Sodium is not good for the body. So function of kidney is to let the sodium go. Sodium is retained only when it is instructed by the brain. Right? So we saw that entire system. So basic function is sodium excretion. But now the kidney is damaged, so there could be sodium retention. Inability of the kidney to throw the sodium out. If the sodium is not going out, sodium is retained. Sodium is retained, water follows. Right? We saw that. Water follows because of the increase in plasma osmolarity. Right? So water follows, and when the water follows, you know that plasma volume increase, and that will lead to increased blood pressure. Correct? So this is the first thing. Second, because remember, this is a chronic kidney disease, right? So it is a long-standing disease. When it is a long-standing disease, the second thing what can really occur is it will lead to increase renin angiotensin. The RAS would be stimulated. Renin angiotensin aldosterone system, that would be stimulated. And third thing, there would be increase in the sympathetic activity. Sympathetic activity. We'll be discussing about certain medicines also, but very brief, because we'll be talking about those medicines which you find that in your day-to-day life people take say paracetamol, people take diclofenac, ketophenol, right? So casually, jara sa dard hai, and if someone is having osteoarthritis, so you just give that, right? But what are the effects? What can they really do? Because the point is that now we are talking about something which is long-standing. 1 or 2 tablets, nothing would happen. But this is about long-standing. So this is the first thing, chronic kidney disease. This is very much associated. Next one is, this is very interesting. There is, in sleep, right? Not everyone, but you must have noticed that in some cases, this is what is called as the obstructive sleep apnea. Obstructive sleep apnea. Apnea means, dyspnea means difficulty in breathing, right? You have heard this name, correct? Dyspnea. Dyspnea means difficulty. Apnea is low breathing. So dyspnea is difficulty in breathing, apnea is no breathing. These are, I would not say these are the symptoms, because symptoms, these are the conditions which are associated with hypertension, right? So in fact, it is the other way around. These are the conditions with which hypertension is associated. So because we say now, our today's topic is secondary hypertension. So when we say secondary hypertension means there is some primary cause, right? There is some primary cause, say for example, chronic kidney disease. And in chronic kidney disease, not everyone, we'll be discussing very shortly why it doesn't happen with everyone. But in chronic kidney disease, almost 80% of the patients will be having hypertension. So this hypertension is because of chronic kidney disease. So chronic kidney disease is a primary thing, and hypertension is a secondary thing. Secondary means which is because of the primary cause. And here the primary cause is kidney is affected. Got it? So that is the topic for today. So be very clear that what exactly are we trying to discuss. So over here, when we say chronic kidney disease, so then why blood pressure should rise? Because kidneys function is to throw away the sodium out. Sodium is not getting thrown out. So then water follows. Right? So sodium is retained, and when the sodium is retained, right? So that will lead to all the complications. Obstructive sleep apnea. This is very interesting. Apnea is difficulty in breathing. Difficulty in breathing. So that is dyspnea. Apnea is no breathing. Actually, patient stops breathing when patient is in sleep, and this is because of the obstruction. Right? This is related, this is a breathing disorder. But during sleep, because of that obstruction, that breathing stops. When this breathing stops, so this is like an emergency, right? So there would be stimulation of the sympathetic nervous system, sympathetic activity. The moment there is sympathetic activity, yes, what will happen? Right? It will lead to increased blood pressure. So here there will be episodes. It is not so that patient will be able to breathe at all, but there will be episodes that for short duration patient is unable to breathe, and again this is a long-standing thing, and that will lead to increased blood pressure. Importance of this will that when you will be studying the medicine, right? The subject of medicine, and in that when the hypertension is there, there would be one part when there will be history taking. So what questions would you really ask to the patient? That right, you notice that his blood pressure is high, and now your question starts, because from question, by asking the question, you are trying to eliminate that what could be the cause. You are trying to come to some diagnosis. Right? So there are, let's say in your mind there are 5 diagnoses, but you are asking the question to rule out one by one. And this art is called as the differential diagnosis. How will you differentiate various diagnoses? By asking the questions. This is the reason why history taking is so important. If correct history is taken, so then you'll be going for the blood test or any of the investigative tests just to rule out that final things. It's not so that straight away you'll be giving battery of tests, list of long tests, right? You go for all those tests. No, you'll be going for, let's say, we will see that case, right? But you'll see that blood pressure is high, but patient has got no symptoms. You might say, okay, let's do the ultrasound. Patient will say, why I am fine. But when you do ultrasound, you find that yes, one of the renal artery is stenosed. But because it is what is called as the aldosterone escape mechanism, by which the opposite kidney is taking care of it, so that there won't be any fluid overload symptom, but blood pressure is high. Yeah, we'll discuss that thing in more detail. But this is what it is in my mind, that right from the beginning, yes, as such, when we'll be studying medicine, this thing will be emphasized a lot, and almost for say more than 20 lectures they'll be on. Let's say if someone tells fever, yes, okay, let's start with fever and then how to diagnose, what are the things, right? Someone tells coughing means khasi, right? So that is, sputum is something what comes out of the mouth, right? So all these are what are called as the symptoms. Symptoms is what patient tells, I am having this problem, and then what you elicit, it is called as the sign. So sign is by a doctor and symptoms, they are by the patient. Patient will simply say, I am having headache, sir patata. But then you will be asking that what type of headache, when it occurred, right? So there is a complete sequence where if you follow that sequence, you'll definitely be reaching to the diagnosis. Sputum, it is called as sputum. Sputum is what comes out of the mouth, right? Normally the patient would say cough nikla. Now that cough, which could be of yellow color, which could be of white color, if there is say carcinoma, then there can be blood which might be coming out of it, right? So even that sputum itself is a huge topic. No, Aditya, we can't diagnose just from this much that what is the diagnosis if someone coughs every time since 2 months. No, we can't say that. But one thing is very sure, that if it is more than three weeks, right, and still something has not subsided, so that is definitely there is a respiratory system involvement. Yeah, there can be variety in sputum depending on the cause of disease, absolutely. So that's what I said, that sputum, it's, say for example, if someone is having bronchiectasis. So in bronchiectasis, that sputum is foul smelling. There is a very bad smell. The amount of sputum itself is so high, right? If someone is having carcinoma, so initially the sputum was not, it was whitish, but then it started with reddish tinge. That means the blood has started coming out. If there is some major injury, then there can be the absolute frank red blood sputum. Right? So many things. For example, in tuberculosis, right, it is yellowish. So that all these are like giant topics, all of them. And at that point, blood pressure, that would be also coming up again. Because by that time, you will be masters of not only physiology, but the pathology, endocrine, and the pharmacology. Because even taking some medicines, that will also lead to increased blood pressure. So that's why what today you will be learning is, just remember, after about 2 years, we'll be discussing this thing again, but in amazing detail. But this is like preparing your brains that this should be the pattern of learning. Otherwise, say it is very easy that yes, reason 1, 2, 3, 4, 5, 6, we go and we finish it. Right? But no. So yes, you can ask any question. Keep asking. Yes. In fact, I like it when you ask. Right? So who the doctor is, who can differential diagnose better? Was how, think from the patient's perspective. Patient would say that yes, he made the diagnosis and unhone dawai di and I was fine. But that's just for this much thing we are studying. So that's why your clarity and your understanding is so vital. right? So first thing so that's the reason that in hypertension, and this is one of the prime question in USM, right? You'll be given the list and all those questions there'll be statements, and it will be said that which statement is not pertaining to hypertension history. Many times people click on this. Now, this is one of the very important reasons that during sleep, because of which is called as the obstructive sleep apnea, right? And there is a machine which is called as the CPAP machine. So when we'll be talking about it, we'll see that machine is attached. So it won't let the patients breathe obstructed, and blood pressure comes down. Because over here, blood pressure is because of simple sympathetic activity. So somehow, if you just suppress that sympathetic activity so that patient breathes normally, you'll be fine, right? Your patient would be fine. So this is the second. First one though is always kidney disease, chronic kidney disease. We'll come back to that in more detail. These are some very vital. The third one it is called as the NSAID. Right? Not a very big thing. This is D for drugs. Right? This is AI is not artificial intelligence, but over here it is anti-inflammatory. Right? These are the drugs which are used so much, and because they are available as OTC, over the counter, no prescription is needed. So that's why people keep on consuming it in a large dose. NS is non-steroidal. So just from this statement, you must have make out that there will be steroidal also. Yeah, definitely, right? These are the drugs. So the way we have non-steroidal anti-inflammatory drugs, similarly there are steroidal anti-inflammatory drugs. Steroidal anti-inflammatory drugs, they are not person won't get it without prescription. So no one can abuse it, take it as per his or her wish. But these are some very common. I'll tell you the name. Say, for example, you must have heard Brufen, right? Or it is ibuprofen, right? That is the content. It's basically Brufen is the brand name, right? So ibuprofen, so common. Diclofenac. Right? Diclofenac is coming in two salts: diclofenac sodium and diclofenac potassium. When we'll discuss this, so at that point we'll go into more detail that what really happens to sodium salt and what happens to the potassium salt, right? Then one very powerful, ketorolac, right? So all these they are basically painkillers. Right? All these, they are collectively called as non-steroidal anti-inflammatory drugs. Vitamin supplement, do they also have side effects? Mostly not. But vitamins means which vitamin are we talking about? And that's very important. Say, for example, if someone is taking which painkiller, no, that's what I'm telling. Almost all non-steroidal. Okay, just keep the questions on hold. Let's finish. You'll automatically get that. Okay, so NSAID, so these Brufen, diclofenac, ketorolac, they're very powerful. Right? And at times, one needs to give them. But what will they really do? Let's understand that. I'll be very simple in this, that what it will do. All these non-steroidal anti-inflammatory drugs, they inhibit. Inhibit means they stop. Right? What they stop? There is something what is called as the cyclooxygenase. Cyclooxygenase. And where? In kidneys. In kidneys. So this cyclooxygenase that is produced in kidneys, right? Now this cyclooxygenase is very important because what it will do is cyclooxygenase will lead to synthesis of prostaglandins. You have heard of this name even before also, prostaglandins. Right? But this is a special prostaglandin. This is called as the prostaglandin 2. Right? This is prostaglandin 2. What is its importance? cyclooxygenase, which is produced by the kidney, right? It will synthesize prostaglandin 2, and this prostaglandin 2 is a very powerful renal vasodilator. Now it makes sense, correct? See, it will inhibit cyclooxygenase. Cyclooxygenase inhibited, so then what would happen? Prostaglandin 2, that would be inhibited. If that is inhibited, what would happen? Renal vasodilation stops. So that means it will lead to vasoconstriction. Vasoconstriction, right? So when the vasoconstriction, and that also renal vasoconstriction. So when that thing occurs, what would happen? You have learned the whole system. The moment there is renal vasoconstriction, right? Kidneys would think like that there is, there is compression, right? It is restricted, and that will lead to the entire cycle. The entire RAS system would be activated. So the point is, what if someone's kidney is already damaged, and then that person is taking this painkiller? How dangerous, right? So this will exaggerate. That's why when we'll be learning NSAID, there'll be one small sentence. And what that small sentence would be? That small sentence would be that it is contraindicated in a patient with kidney failure. This is a reason. Right? This is a reason. So, and once this thing occurs, right, when the vasoconstriction occurs, so what it will do? There would be decreased renal blood flow, because less blood is going now inside, right? Decreased renal blood flow. So there would be decreased GFR. GFR is glomerular filtration rate. That is at what speed? So here, this is the afferent. These are the tuft of capillaries. This is the efferent. This is the Bowman's capsule, right? So glomerular filtration rate, this whole thing is called as the glomerulus. So at what rate it is really filtering the blood? So obviously less blood is going, so there would be decreased glomerular filtration rate, right? Filtration rate. In anyone, many times you'll see that people go for that complete blood checkup. In that, there would be one thing, GFR. Right? So in any case, when you find that GFR is less than 80, be alarmed. Right? So this is one of the tests. On one page, there would be written GFR. So this is the thing. Now, what will really happen? Due to this, there is decreased afferent arteries are bigger than the efferent. That's right. That's right. That's why it goes for what is called as the ultrafiltration, right? The same principle of the jet engines. In jet engine, you'll see that on the sides of the wings, it is always like this. There will be huge, big propeller, right? There will be, so they suck the air, large amount of air is sucked, and then that, and because it gets heated, and then it is propelled from this small space, right? So that the pressure is generated. Same thing is here also, ultrafiltration. So afferents, they are bigger, efferents, they are smaller, so that pressure is generated, so then yes, it is pushed, correct? So that is how it will be goes. Bernoulli's principle, yeah, same thing, right? But Bernoulli's was like what? Right? That is the principle by which the air lifts because of the shape, and then more number of those movement of the particles depending upon the surface. Okay, so coming back to this, so what I was telling is there would be decreased sodium excretion. Body is retaining sodium is not excreted, so water is also not getting excreted. Water is also retained. Water is retained, it will lead to increased blood pressure. The side effect, it will affect heart. Right? And this is where there would be increased plasma volume. When there is increased plasma volume, so that will lead to accumulation of more amount of fluid into the lungs, what is called as the pulmonary edema. Pulmonary edema. So there is something what is called as the rails. When we'll be learning auscultation, so there are two types of sounds. One what is called as the cardiac sound, heart, right? When the heart beats, that is seedha sada, that the valves when they close, they make the sound. When they open, they don't make the sound, right? Blood when it is going with sharafat, right? So there is no sound. But when the blood is going through narrow space, so it turbulates. So that turbulence that leads to generation of the sound, which is called as the murmur. So whether the murmur is systolic or diastolic, and accordingly will be diagnosed. So these are collectively called as, no doubt there are first heart sound, second heart sound, clicks, all those things. But basically the sound which are generated by the heart. The second group of sound is called as the lung sounds, respiratory system. So at times when we say, so for example, if someone is having asthma, so when you say breathe, they'll breathe like that wheeze would be heard. And once you hear that, you'll never forget. So when we'll be discussing this auscultation means using your stethoscope, what exactly you hear, right? I got all recorded sounds, but we'll be able to play that thing at a variable speed. Because think it like that when the heart is beating at a very rapid rate, right? Over here, the heart rate will be higher. When the heart rate is higher, so not much. We just say that heart rate is just 120 BPM, beats per minute. So that means one beat is in 0.5 second. Within 0.5 second, systole, diastole, all those murmurs, first heart sound, second heart sound, whatever, all those things have occurred, and it is occurring again and again and again. So every half a second, in 1 second, it is happening 2 times. So that's the reason that initially, for the understanding, what we'll do, we'll slow it down. We'll slow it down to 10 times, so that this entire process will be taking 5. So we'll say, right, that first heart, right? So we'll actually draw first heart, and then the murmur, and then comes the second heart sound. So then I'll say that, see this murmur, this is abnormal. Right? First we'll hear lubbed up, a healthy heart, right? And then gradually we'll start adding all these abnormal components one after the other. Right? Once you are clear that yes, this is the initial sound, right? When you find that yes, this is the initial murmur, or in some cases it will happen like the murmur is occurring at the end, or sometimes it is holosystolic. Holosystolic means during the entire phase of systole, that sound is coming. So when you'll start identifying it, gradually we'll start increasing the speed. Right? So it has to be like a visual picture into your brain and the coordination of your ears. Right? It requires some practice, but trust me, this is how we'll generate. Now, same way, there are more than 20 different type of sounds which you must. Now, in order to mimic those sounds, what we'll do is, say for example, we'll have a cup, right? We'll put some water into it, and then with straw, I'll blow it, and you hear that sound, and then I'll play the real sound. So if it is simple water, the sound would be different. Then let's say if it is filled with some thick cream, and then you blow, then the sound would be different. But right, crepitations. It is called as crepitation because fluid is thick. So with that concept, what you hear, right, you'll be able to judge. And then comes there would be your anatomy, right? So when we say that, okay, you are hearing it over here, so that means the basal lobe, also called as a lower lobe. Lower lobe is involved, right? In lower lobe also, you want to be sure to you'll auscultate from the back, from the front, so that you come to know that exactly where the things are. And then you'll be going for X-ray chest, and then you will confirm that yes, there is consolidation into this area. right? And you know it very well that the diaphragm would be obscure. So that is how you'll be correlating your clinical findings with the investigative findings, right? Instead of going straight away, go for XHS, you saw, acha, it is this. But then where is your skill, right? So auscultation is something which is so amazing, right? And auscultation is like combination of it. And when at this point, you might feel like, just in half a second, everything is occurring. Yes. But same way, say those who are table tennis player, right? I just watch cricket. I'm not good in cricket, but I play reasonably okay table tennis. Now, in that, when the ball is struck, right, the table is there, small net, right? In 1 second, at times, if the player is good, and so it goes, right? And in 1 second, 3 or 4 times the ball moves in 1 second, right? At times it is so fast. It's one backhand, second forehand, and your opposite person has returned. So it goes that fast. It is nothing but reflex. Your brain can also analyze these things at a faster pace. But the same way I'll always give the principle of table tennis, you need to practice, right? You need to anticipate. If this type of sound is there, so what could be? And then we'll be utilizing the speciality of your stethoscope. If you rotate, in your stethoscope, there is one area what is called as the diaphragm, right? Which is normally, always diaphragm is used. But then there is a small area, very small area, and it is called as the bell of the diaphragm. Yeah, exactly, bell. So that bell, and this is the neck of the neck of your stethoscope, right? And then the tubing and everything. So when we want to listen to very subtle frequencies, very delicate frequencies, right? Especially in case of mitral stenosis, and you rotate the patient into left lateral position, and then you turn your bell on, and you hold your stethoscope with the neck, and then very delicately you just put it, you'll be able to listen to some amazing things, which is never heard by the diaphragm, because diaphragm you'll be holding like this, right, between two fingers, right, and you'll be pressing it. Yes, that's the way to use the stethoscope. You'll be pressing it because you don't want that air gap inside. So you just press it and you will hear. But it damps certain specific frequencies. So now if you are suspecting that this is mitral stenosis, patient into left lateral position, use the bell, delicately put, and those frequencies will start, because it is the turbulence which you will start watching, right? So that's the importance of diaphragm and the bell. More when we'll be discussing that, we'll be in that though we'll be talking even about the acoustics, right? And at times people say that say Bose or JBL, right? All those, their headphones, they are costing 30,000, 40,000. Why they are so costly? Right? There is a reason behind it. So we'll be discussing even that part. So that one stethoscope which is of just 300 rupees, another stethoscope which is of 30,000 rupees. So what is that where they are charging? Right? So that also we'll understand. Okay. So coming back to this, so over here, when there is increased blood pressure, right, heart is failing. If the heart is working properly, so then it won't let anything go wrong, right? It will keep on working. But then as things become chronic, so it will start affecting the heart. And now the heart is unable to pump the blood with that power, and that will lead to pulmonary edema. And one of the things is, what you hear on stethoscope, it is called as the rales, right? Rales. Just keep in mind this word, right? I'm just writing, it is auscultatory finding. Auscultatory finding. So, as a question was asked that, is this not now, but it was asked in 1 or 2 lectures back. Yes, with the help of stethoscope, many of the diagnoses can be done. Many. And this rales, that is a very difficult sound. So these are the, and the question which you asked is, which one is safe? See, NSAIDs, they are as such safe. This is only for those cases when someone is taking twice a day, right, morning, evening, to whom it will, if someone is having severe osteoarthritis, aged patient, right, body is compromised, immune system is compromised, kidneys, they are compromised, and then they are having severe osteoarthritis, and for some reason, patient's condition is such that you can't advise, say, total knee replacement, TKR, or in some cases when their D3 level is low. You must have heard they slip and they break their neck of the femur, one of the very common hip. This fracture, neck of femur, this is broken. Because their calcium level and D3 level, they are pathetically. Means recently one of my couple student, right, they came from London, age must be 32. Their D3 levels, you'll be shocked to hear that male was having D3 of 6 and female was having D3 of 5.2. Seriously gullible. I mean, so low. Normal range? Well, it should be. It is below 10, so it is unpardonable. 20 to 30 is called as insufficiency. 30 to 40, this is insufficiency. 30 to 40, it is considered as less, but still pardonable. Should be in the range of 40 to 60. That is awesome. This is very good. And there is a very simple way to increase it. Very simple way. And that is every morning, right? Watch for sunlight for 5 minutes. Very powerful. And then it is like at times it depends upon the diet also. So all you need to do is just you have to take that tablet, cholecalciferol, 60,000 units, and just take one that gel a week. Bus. Again, depending upon what's the condition, but we have seen that many of time it is in the range of between say 20 to 30. So this cholecalciferol, 60,000, 60K IU international units. Sorry, 60,000 units per week. So you can select any of the one specific day and on that day. Yes, Kushi, this is vitamin D. Or if the level is, say for example, I don't take it once a week, but when you are going for such strenuous exercise, say my level is 56, so I take per week 5,000 units. 5,000 international units per week. This is for the maintenance, so that level is not dropped. So all these things are what, then when someone shows you the report, everything matters. Only test can tell D3 levels. Yes, only test can tell really what's the D3 level. And when you are going for D3 level, don't forget to go for your D12 also. Because see, being a student, right, your brain, they are your biggest asset. I don't know about, I think in the initial lectures, I told that you just get your D12 and D3 done properly. Right? And I got many of the reports. If B12 level is less than 200, you will find that it is very difficult to focus, right? Very difficult to focus. You become irritable, right? Some occult pain. मतलब कुछ नहीं किया तो भी there is pain in the shoulder, pain in the neck, and all those weird things they are occurring. B12, that is so vital. And cost of that B12 tablet is 3 rupees. Is 3 rupees. It is that less. Bacozyme C4 is a combination, right? But if someone is having very severely low B12, then they have to take specifically. And if you can take sublingual, that is best. And just put it under the tongue, it gets dissolved, and that is fine. Okay. The next is when you are taking history, you will ask your patient that is your patient on two things. One, OCP, oral contraceptive pills. Right? Oral contraceptive pills. You see, oral contraceptive pills are what? They are the combination of estrogen and progesterone, right? So estrogen and progesterone. So what is the function of oral contraceptive pill? It won't allow, even if it is fertilized, it won't allow it to, say, embed into the uterus, right? It won't allow that. So here the estrogen and progesterone, they are called as the estrogen and progesterone analogs, right? Estrogen and progesterone analogs. And their side effect is that increase blood pressure. But this increased blood pressure is not severe. It is not so that it will skyrocket. There would be mild increase, right? And this increase would be mostly systolic. Could be mostly systolic, right? The effect of estrogen. Because estrogen is a very powerful sex hormone. Say, if testosterone is considered as male sex hormone, if it is considered as 1, estrogen is 16x. It is that powerful. Okay, so that's why the history taking is important. That is the patient on this OCP. Another very commonly abused drug. If someone is having cough, right? That phenylephrine and then this green-linctus and Benadryl, right? ये भर के पी जाए, right? मतलब people use those cough syrups, right? Those cough syrups so casually. Now these cough syrups, they are having one component which is called as the pseudoephedrine. Again, ephedrine, pseudoephedrine, all those things will. But what is its function? Nasal decongestant. Right? Nasal decongestant. So it is a nasal decongestant. That means if the nose is blocked, right, it relieves it, and person feels good. But how it has relieved that? The nasal congestion is because there was so much of increased nasal blood flow, right? So because of that blood flow, the vessels, they were dilated. What this pseudoephedrine did, pseudoephedrine led to nasal decongested by vasoconstriction. Correct? Vasoconstriction. Its prime function is what? Decrease nasal blood flow. So if someone is having running nose, running nose is what? Basically, it is that fluid which is coming out. So it dries up everything. But it dries up at what cost? Right? It dries up at the cost of that vasoconstriction. When the vasoconstriction is done, now you know, right, it will lead to increased blood pressure. So this is how it will lead to increased blood pressure. But these are transient. These are transient. So sir, is good or bad? Like, does it have any effect on body? There won't be any effect on body. The thing is that you give this ephedrine, pseudoephedrine to someone, and then if you are not taking the history and you check the blood pressure, you find his blood pressure is 160/90, and you start the antihypertensive. Now that patient was doing like that, right? So that should be the hint that just ask. Now, if you have not asked, right, you start this treatment, so patient may lead to hypotension because this nasal decongestant people take for 1 or 2 days. So that's why it is important. That's why I said that this increased blood pressure is transient. Transient. Even you don't have to do anything. Even if you don't do anything, then it will come back to normal, right? So, and your question that is it good or bad? Well, every drug, right, it has got some effect, because either it will be stimulating sympathetic system or it will be stimulating parasympathetic system. So somewhere something is getting compromised, but your purpose is that how to handle this particular situation. So that's why. Say personally, if you ask me many times, I don't take any of the medicine. I got this thumb injured today only, right? Badly injured. So with this hand, I can't lift even a cup of coffee because I think ligament injury is there. One of the neighbor, right, he was having that bullet. So I just parked and then he said hello. And as he was trying to put it on stand, the whole bike tilted. So in order to save him, so but the thumb was abruptly, say, bent on the opposite side. So when I came up, so found that yes, there is some swelling. But say for this, one method is I take diclofenac. If I take diclofenac, yes, within say 2 hours, it would be fine. If person drinks cough syrup, it is obviously. If person drinks cough syrup as a juice, so definitely harmful. Definitely harmful. Because it is not so in cough syrup, there are so many things. And people, you know why people like cough syrup? Because it has got alcohol content. Yeah, it has got alcohol content. So at times, those who are addict, they drink the puri bottle, right? They drink it because it has got alcohol content. So for the kick. So that's a thing, codeine. Right? Next, this is like, say, if someone is on immunosuppressants. After drinking, नींद बहुत ज़्यादा आती है due to alcohol. हाँ, absolutely. It is because of. So see, the thing is, it's a good thing that even if you drink this much of एक चम्मच, you took this cough syrup, and still if you are feeling sleepy, that means everything is going very good and your body is responding very properly. Because as the addiction increases, right, you know, people say that मैं तो 4 पैक पी के भी कुछ नहीं होता और 5 पैक पी के भी कुछ नहीं होता. It is all nonsense. Brain is affected. People think doctors self-prescribe medicine for themselves, but knowing doctors don't take the medicine. हाँ, बिल्कुल सही. Say, I used, right, as soon as this lecture is complete, I'll be again icing it, right? So it is what is called as the rest, icing, compression, and you just give the elastocrate bandage, rice. So that is sufficient. And yes, medicines, when you take painkiller to this, its effect would be drastic. But as far as possible, don't put anything into the mouth. Don't eat it. There are good sprays available even during run also. Many times there are cramps. So, you know, one thing is you take painkiller, or over there the fruits are available. So you have pineapple. When you have pineapple, so then it will give you potassium. Potassium will immediately relieve those cramps. Or घर से, in small packet, take a small amount of that salt with you. So whenever you feel like, you know, cramps are about to come, just take a pinch and put it on your tongue. You'll be fine. So painkillers, so they are like a last resort. Then it is a different thing. Anyway, so coming back to this is the immunosuppressants. All immunosuppressants, they are renal vasoconstrictors. they lead to renal vasoconstriction. When there is renal vasoconstriction, less blood is going. So there would be more salt and water retention into the plasma, and that is what will lead to increase in the blood pressure. So salt and water retention. Retention means it keeps it into the body. So you can, either way, you can write it like this, or it decreases excretion. Right? It's one and the same thing. So that is what is called as the renal vasoconstriction. Now, how it occurs, how it really, there is formation of what is inhibition of calcineurin, etc. When we'll be discussing the pharmacology. Right? But at least at this point of time, if you find that yes, it is happening, immunosuppressants, someone is taking, so it can lead to this. One of the very interesting thing, and which you must diagnose very properly, and that is whenever there is excessive levels of aldosterone. The moment we talk about aldosterone, right, this is from adrenal glands. And these aldosterone, what will they do? Right? This will lead to increased blood pressure, right, by its effect on kidneys. But there is increased level of aldosterone. Why should it really increase? Right? Over here, there can be two reasons. One, the aldosterone level increased because of stimulation of RAS. When it is not due to RAS, then it is called as the primary aldosteronism. This is primary aldosteronism, right? But due to RAS, if it happens, it is called as physiological. And when it is occurring without the involvement of RAS, then this is pathological. So, in which condition? Both simple. Very simple. Tumor of adrenal glands. So that tumor, because it is a pathological tissue, so that will keep on releasing aldosterone, limitless, right? Because it is a pathological tumor. So what is cancer? Tumor, when we say cancer, so what is cancer? Cancer, these are those cells, whether it is benign or malignant, but they are those cells who are proliferating. They are immature. They are not taking part into the betterment of the body, but they are consuming the nutrition. So same way, technically, if you say, you will call this thing as adrenal adenoma. Adrenal adenoma. Whenever the word oma comes, that means we are dealing with a tumor. Right? So this is what is called as the adrenal adenoma. So in that case, because that tumor, it will keep on producing the aldosterone. Aldosterone once into the body will say, okay, as you say, and it will start working, right? And it will increase the blood pressure. But this is because of the primary aldosterone. So there is no RAS system involved. Correct? So, by the way, this thing is also called as the Conn's syndrome. All these are topics, right? When we'll be discussing endocrine, these things will be coming in more detail. And where you have to really differentiate. This is where it will come into picture that see whether to go for ultrasound, whether to go for CT scan or MRI or any of the other things. But important, the case has come, and this case is like what you saw, that there is increase, right? Say aldosterone effect. So aldosterone will be affecting those distal nephrons, right? Distal nephrons, that is the distal convoluted tubule and the collecting tubule, correct? And what it will say? It will say sodium should not go out, correct? It will take the sodium back. So there is increased sodium reabsorption. Right? So this is the aldosterone effect. Aldosterone, that is what it is doing. It take it back. If it is taking the sodium, then the water will also be taken. So water is also taken back. Right? So that is increased water reabsorption. What will happen because of this? Increase plasma volume. Right? Increase plasma volume. That increase in plasma volume. So now large amount of blood is going. Right? This will increase. After preload. This will increase preload because atrias will be properly must filled. Right? Guns loaded. It will lead to increased cardiac output. Correct? Increased cardiac output. And right from the beginning, when we say cardiac output multiplied by total peripheral resistance, that will lead to increased blood pressure. Yes, there is increased blood pressure. But when you are going for this, you ordered that, yes, my patient should be, you go for these tests and you said that go for serum sodium, serum potassium, and patient's relatives say, yeah, doctor, unnecessary, right? It's so many tests. This serum potassium, we have discussed. Why we are going for serum potassium? Because aldosterone has got one more effect. It increases potassium excretion. So that means this patient will be developing hypokalemia. Decreased potassium. This decreased potassium will straight away affect the heart. Right? So that's why all these values, they matter a lot. So when you are watching someone's report, right, think that every line, every report has got a meaning. Right? When we'll be discussing this blood, right? Blood hematology. So in that, I told you that we'll be watching several reports in depth. Right? Not only say that is what is called as the CBC. So TC, total count, differential count, that what has happened to those eosinophils, right? Lymphocytes, all those things, their proportion, their ratios, and from this we can very well take a judgment whether it is a bacterial infection, whether it is a viral infection, whether it is allergic, whether it is parasitic, so that we know that what drug to be given. So over here, a very important thing, one of the question of yours, that in case of primary aldosteronism, you'll definitely be going for serum potassium test. Right? So that you know that because of extra aldosterone, it will lead to increased potassium excretion, which may lead to hypokalemia. So before it develops, you just take care of it. Now, if you want to take care of it, then you have to decrease, you have to give such medicine which should not allow the potassium to excrete. And that is what is called as the potassium sparing diuretics. Potassium sparing diuretics. Now it makes sense, right? Potassium diuretics. Why you want to give diuretics? Because you want those to let the fluid go into the urine so that you have to load come. Correct? So you are giving diuretics. But when you are giving diuretics, potassium will be bhag raha hai. You don't want that. So that's why it is called as potassium sparing diuretic. And that's why in such cases, the drug of choice becomes spironolactone. Right. Why I am giving you the names? So that once you hear, it will generate some spark. Even if you forget, no problem. Right? But when we'll be discussing this thing for the second time now, suddenly it will flash, we talked about it. Right? So that becomes very interesting. Achha. Another wonderful concept. It is what is called as the aldosterone escape. It is called as aldosterone escape. In this aldosterone escape, when the aldosterone is high, then right there, because aldosterone won't let the fluid go, so there will be loads of fluid into the body, increase plasma levels. So that will lead to all the complications of what is called as the volume overload. Volume overload. Because there will be pulmonary edema, right? There will be PAUME, there would be pitting edema, right? Pitting edema. So this is the foot, right? You just keep it pressed to khadda, right? There will be khadda. That is what is called as the pitting edema. Pitting edema. And whenever there is right heart failure, you will find pitting edema is there. So if you press and you find that there is that pit khadda, then you are dealing with a right heart failure, right? So over here, because of volume overload, there is pitting edema. You just put and you find that rails, right? Rails, what we discussed, rails, auscultatory finding. Right? Once you will hear, you will find that it is not that complicated. There's a pani beh raha ho, that type of sound. And then this is the jugular vein, right? There is, you'll find that jugular veins, they are prominent. So there is increased jugular JVP, is a jugular venous pressure. Jugular venous pressure. Why this jugular venous pressure? Why should it really increase? For a simple reason. That's the heart, right? So over here, superior vena cava. Superior vena cava, they are made with those brachiocephalic vein and jugular veins. They are landing over here, right? So when the pressure is high, so it is the back pressure which will make them more prominent, correct? So that because of that back pressure. So this is all aldosterone effect. Surprisingly, when this is happening, so it is happening because of that sodium and right, fluid retention. They are not going out, and at the same time the potassium is going out. Right? Aldosterone escape is that mechanism when there is one more component which comes into picture, and that is ANP. Where on the foot we are supposed to check? Okay, sir. The best site is, as such, if just think it like, if this is the foot, correct? If this is the foot, so when the foot is swollen, so you can do it even on the top. Upar dabao, you'll be able to see. But to be precise, on both the sides, there are malleolus, right? If you will see your foot, if this is your heel, right? This is the heel. So there is a bony prominence on both the sides, medial and lateral, right? Malleolus. On that you press, and immediately you will find, yes, there is that pitting. Good question. So what we were discussing was that because of aldosterone, right, there is volume overload. Why it happened? Because all the sodium and fluid retention is there. But there is a compensatory mechanism. And that thing is called as the ANP. Anti-natriuretic peptide. That's right. This is a protein, natriuretic peptide, and it works exactly in the reverse way. The function of ANP is increased sodium and water excretion. So that will lead to diuresis, right? It will lead to diuresis, and we feel, yes, things are good, everything will be normal. So normal status, right? Normal status, it will be retained, but now still patient will be having high blood pressure. The thing is, aldosterone is far more powerful as compared to ANP. So ANP will balance. ANP, anti-natriuretic. Not anti, this is atrial. My mistake. Sorry, atrial. It is from atrial. So atrial natriuretic peptide. So this is from heart, right? This is from heart. So it is trying to balance it, but that balance will not be that powerful. So due to this, a very typical thing occurs. You take the blood pressure and you find the blood pressure is high, but patient is not having any symptom of volume overload. So here, no volume overload symptoms. When you get such thing, because patient is not having anything, no edema, nothing, right? No jugular pulse, no rails, you auscultate, everything is normal. How is it possible? And how is it possible? So in such cases, when you find that this is, no doubt, you need to investigate for renin also, that is the renin level. But when you know that this aldosterone, right, this is the diagnostic point, renin independent aldosterone rise. One thing is that. So, right, aldosterone has increased, renin independent aldosterone. And second, when you find that, this means what? That when you do the blood test, so in that there is increased aldosterone and decreased or normal renin. Right. So now you know that this aldosterone rise is not because of RAS. So this is the case. And then you just check. You just check that what is the serum potassium. And you will find this thing low. Right. This thing low. You try to give all the other medicines. You give Lasix and hydroxyzine, and you'll find that this patient is not getting, his blood pressure is not coming down. Right? So that is what is called as the resistant hypertension. And what's the reason? Taking only the blood pressure and not going for these tests will not tell you that this is renin independent aldosterone. So that's the thing. In such cases, all you need to do is you have to go for the treatment part. You have to go for, I'm going into slightly more detail, but you will understand. You have to go for what is called as the aldosterone antagonist. So what is aldosterone antagonist? Antagonist means ulta, means someone who is preventing the aldosterone. And that thing, that name of the drug is spironolactone, what we talked about. Spironolactone. So that's how spironolactone acts. It goes at its root. Right? It inhibits the aldosterone. Right? And because aldosterone was letting the potassium go, this spironolactone, it stopped aldosterone. So now it is potassium sparing. It is not letting the potassium go. So thus patient's hypokalemia is taken care of. While there are other drugs for hypertension, what they do is they try to decrease the fluid. So they try to go for vasodilation, right? So that pressure is decreased. But it is the aldosterone which is constantly working. So you give the medicine, blood pressure reduced for some time, then again it rises. So this is because aldosterone is non-stop working. It's coming from those adenomas, right? So in such case, the spironolactone will be very effective. Then you will adjust the dose depending upon that how much is the blood pressure. Correct? Last thing, what if there is a tumor, right? But this tumor is bad, adrenal gland tumor. And this is pheochromocytoma. what was that this was doing over here also, right? We said na primary aldosteronism, and that was because of tumor of adrenal gland, correct? And what is it doing? It was releasing aldosterone in more quantity. So over here also we wrote the same thing, adrenal gland tumor, pheochromocytoma. But this pheochromocytoma, this is a different type of tumor. This is a tumor which will secrete catecholamines. When we started the topic, we discussed that if there is someone will keep on stimulating sympathetic system, so that will also lead to increase in the blood pressure. This is what it is. The catecholamines, that means adrenaline, noradrenaline, dopamine, right? So all those things, they are released by this. They are catecholamines, adrenaline, epinephrine, norepinephrine. So noradrenaline. So they are stimulants of sympathetic. So now we have got a tumor who is straight away leading to release of these. And when this thing occurs, right? So this is stimulation of sympathetic activity. So now there is completely different etiology. How will you diagnose this thing? Now for these catecholamines, there are some breakdown products because they get synthesized. Right? These are the breakdown products. Breakdown means when it is synthesized, it will lead to certain substances in which there is one what is called as the VMA, vinyl mandelic acid. So you will go for it, right? This vinyl mandelic acid, you can say this is nothing but it is a breakdown product of catecholamines. When this level is rising, you guess that catecholamines are rising. There are more catecholamines. Now, what would be the symptom? This patient would be extremely anxious, right? And that's why there is one thing which is called as, remember it like a triad. 3 things occur together. And those 3 things you remember from here. Right? So at times, people write pheochromocytoma like this, PHE, and then O-chromocytoma. So this PH, the first one P, second one H, third one is E. First thing, it is called as the palpitations. Palpitation is normally right now your heart is beating, but you will not feel. But then at times you feel that yes, the heart is beating. Right? There can be various reasons, but say this is what is called as feeling your own beating heart, correct? So that is what we call as the palpitation. But it is associated with headache. There is headache. And third, and a very typical thing is this third one. It is called as the episodic sweating. For no reason, right? Patient is sitting and they will be sweating like anything, right? Pasina pocha, 2 minutes, 5 minutes, okay, and then once again sweating, because this is constant stimulation of the sympathetic system. So this is what really happens. This triad, if it is there, so then you go for the VMA. VMA is vinyl mandelic acid, and you find that this is high. That means patient should be subjected to CT or MRI, right? Because on ultrasound, sometimes you won't be able to see the pheochromocytoma if it is very small. But on CT or MRI, you will be able to see. There are even other tests also. But this is just the indication that how you will be approaching to the patient, right? How you will be approaching to that particular thing. One more thing. For stress hormone, right? Stress hormone. This adrenal glands, so they are like jadoo ka peta. The stress hormone, one of the stress hormone is what? Cortisol. Cortisol. So whether it is in glomerulosa, reticularis, right, or fasciculata, reticularis, right, cortex, medulla, tumor can occur anywhere. So when this cortisol releasing tumors they occur, so then that will lead to this increasing cortisol, and that thing can cause so many complications. Two things. One, cortisol is high. Cortisol can be high due to two reasons. One, person has taken it, steroids, right? It is called as the steroid administration. You will find that in gym, when they lift weight and then suddenly they collapse, right? You will find that they have taken the steroids, and it is what is called as the exogenous steroid. Bahar se liya hua, right? They have taken the injection or the tablets just for the pump, right? Which is not at all advisable. So, but well, people do take. So that thing can lead to this increase. So that is one. Other, when there is tumor. Right? When there is tumor. Now this is like there can be adrenal tumor, right? Adrenal tumor, which is leading to increase in the cortisol. Or pituitary. The entire pituitary axis, right? Our endocrine axis. So from pituitary, there is one hormone which is called as the ACTH, right? Adrenocorticotrophic hormone. Right? So this ACTH, when it is overstimulated, right, it is secreting more. So then that will lead to increased adrenal function. Adrenal glands, they are okay. So if the adrenal glands are okay, then you have to go for the brain scan, right? Because you really want to see the condition of the pituitary. So this is, if that is also normal, then you'll be going for, say, CT thorax. CT thorax. Why CT thorax? Because you want to see. And if the symptoms are patient is coughing, right, and the respiratory compromise is there, so you are expecting what is called as the small cell lung tumor. Because small cell lung tumor can also lead to increase in the ACTH. Right? So this is small cell, and for that you need to go for CT scan. So collectively, the thing is, what we came to that conclusion that cortisol can lead to increased blood pressure. But if you suspect that, then these are the areas from where it can really lead to increase in the blood pressure. And last but not the least, very vital, that's the kidney. That's the aorta. Any of the obstruction. Right? Now this can be even coarctation of aorta. Remember, in coarctation of aorta, we said that this is the arch of aorta and then it is constricted. So if it is constricted, we'll just come to that. Right? So here it is the renal artery. Right? This is the renal artery. Renal artery stenosis. This is the vascular disease. Right? So when this artery is stenosed, right, this artery is narrow. So obviously less blood will be going into the kidneys. Right? So this is what is called as the renal artery stenosis. So that will lead to increase. But in say we say that when the blood is going with sharafat, right, normal tube, right, the blood is going good. But when it is stenosed, right, stenosed means it would be actually something like this. The whole artery is not narrow. It is narrowed at one point. So it is like this. This is typical renal artery stenosis. So when the blood goes through it, that blood is going straight away, but then over here there will be turbulence. There will be turbulence, and then the blood will rotate. And here, if you put the stethoscope, Right? If you put that bell, so then you will be able to hear the sound. Right? That is what is called as the renal brew. Renal brew, very rough sound. You'll be able to hear. Right? So this is no doubt. With the angiography also you can make it out. Each zone of adrenal gland GFR may can have tumors differently. Yes, question. Every tumor, right? Sometimes the tumor develops where it occupies two layers. Right? It might occupy that fasciculata and reticularis. Right? So in that case, the things become complicated. But yes, tumor can affect differently on any of the layer. Okay. So coming back to this is the renal artery stenosis. Right? And usually this is unilateral. Opposite side will be normal. Now, when the opposite side is normal, right, this opposite side is normal, so it will be compensated. It will compensate. So this normal kidney, it compensates. So what will happen? No volume overload. Blood pressure will be more, but that fluid overload, pitting edema, rails, right, those things will not occur. So two important things we learned today. That when there is increased blood pressure, but there are no other sign symptoms. So one thing, it could be because of the renal artery stenosis, or it could be because of that primary aldosteronism. Right? So that's why the proper follow-up and everything is so important for such cases. Another, this is what I wanted to talk about, that coarctation of aorta. Right? This was the coarctation of aorta. So when there is narrowing, right, this is coarctation of aorta. So here there is narrowing. Now the blood vessels which will be coming out of it, so over here it will be, right, three major vessels. Brachiocephalic, this is the common carotid artery, right? This would be the left common carotid artery, and this would be the left subclavian. And then obviously this will be dividing into branches. Over here, what will really happen is, when in case of coarctation of aorta, there is increased blood pressure in upper limb. Because coarctation will be having even other symptoms. So there are methods by which you can take blood pressure even from the lower limb. Right? There are special cuffs available. So there is one cuff which is for upper. There is a cuff which is available for the lower limb. So in such cases, not only this, how will you get the hint? You will find that there will be weak pulse in the lower limb, and weak pulse in the lower limb because it is less blood it is going. So blood pressure would be low, and the weak pulse, weak lower limb pulse. So that will give you the hint that what you are dealing with. So that's it for today. To revise this thing, there are several other conditions also, but some of the conditions, they are like very rare, right? Like dysplasia, etc. So those things, once we learn the pathology properly, at that point we'll go for that. But these are some very primary, very important conditions which as a doctor you must know. Today is Thursday, right? And day after tomorrow, Saturday, there is that race expo. On Sunday we'll be running the full marathon. Right? So we won't be able to meet on this Saturday. That is day after tomorrow. We'll meet straight away. Next time we'll bring the blood reports. We'll keep one full session on these blood reports. Right? Absolutely. Biochemistry, I teach all the 19 subjects of Mbbs. Every subject. It's right from this anatomy, physiology, biochemistry, all the way in ortho surgery, obstetric gynec, pediatric surgery, all 19 subjects. I was in Georgia, I used to take all the 19 subjects. All right, so thank you so much. So once I finish the race, right, I'll share the picture with you. I've been to Georgia 4 times, Kyrgyzstan, Kazakhstan. Okay. Lecture timings means to start at 6:30, it would be slightly difficult, but still, let's see. Right? We'll coordinate. Sure. No, we do have class on Saturday. No, Saturday there is expo, right? Expo is that fair which is on the prior evening of the race. So that expo will start at 3 o'clock in the noon and will continue till 10 o'clock in the night. So I'll be there. I understand. Okay, we'll do something. All right. Thank you for your wishes. Thank you so much. Right. I'll share the picture. I'll show you the medal also. All right. Take care. See you soon. Thank you so much. Thank you. What's your question? So we shouldn't start biochem. I mean, sorry, Ruchit, I didn't get your question properly. We shouldn't start biochem. Biochem is normally, we can start, but after physiology. Reading yourself, definitely you start. Definitely. Do they teach anatomy and physiology? Because the curriculum is a bit different. Chirag, where exactly are you right now? With which university you are talking about? Acha, Bruni. But anatomy and physiology, so they are part of first year only. Maybe. So if not anatomy and physiology, then what do they teach? What are the subjects? Durgesh, that is good. Starting with upper limb, that is definitely good. All right. So see you soon. They are teaching Latin and Georgian. So soon, let's hope, soon they start the subject. So if they have not started, then definitely from my YouTube channel, you can start with the upper limb. Just try to finish it. You will be having enough time. If you finish the upper limb at this stage, it will be a big advantage. You will be able to download all the PDFs because in the comments, in the description, that link is given. So you click on that, it will take you to my Google Drive. And from Google Drive, single shot, you can download all the PDFs. If you wish, you can download all the PDFs of all the regions also. Achha, you are done till 4 hours. Then that is great. No, Chirag, just I think you need to confirm. Definitely they should start anatomy. Because without anatomy and physiology, then how will you study? Okay. See you soon.